Hello everyone. Today we'll be talking about assessment of successful thrombolysis. So as we all are aware of, whenever we clinically we come to whenever we are in clinical practice or we are in emergency department or whenever we are doing our seeing a patient. So often we come across a patient who complains of chest pain. So suddenly whenever your chest pain complaints, you will take an ECG and ECG shows this type of picture. So this is what is called as ST elevations. As we all know, ST elevation is nothing but it is the elevation of this ST segment. So this is the ST segment or the raising of this J point above the baseline. So you can see here, this is the baseline, that is the PR segment. This is the PR segment, and after this, compared to this, there is elevation of this segment. You can see here elevation of around 4 millimeters of elevation is there. You can see here elevation here. So often we come across a patient with ST elevation myocardial infarction, and treatment of which is a fibrinolysis. So there are two ways of treatment of this. If a patient is in a center where cath lab is available, patient will be directly taken for primary angioplasty or primary angiography, and then you do angioplasty based on that. And if you are in a center where you do not have a facility of for cath lab, you may have to do a thrombolysis first. So because this is because of coronary artery occlusion, you do thrombolysis and then you send the patient for a further intervention. So after you do thrombolysis is nothing but giving a fibrinolytic agent, because there is a all these are blocked arteries, and whenever this blocked arteries is there, if the acute thrombus which is present, you have to remove the thrombus so that there is some flow which is going to distal and can save the myocardium. So this is called as fibrinolytic agents which we give, and that is called as thrombolysis. So once you give a thrombolytic agent, how do we assess that whether the thrombolytic agent has worked or not? So this is what is called as assessment of successful thrombolysis. So to assess this, these are four parameters we check. One parameter is clinical, second is by ECG, third is by biomarkers, and fourth is by angiography. So clinically, first we go to clinical assessment. Clinical assessment. So patient generally comes with complaints of chest pain. So diffuse chest heaviness or squeezing type of pain patient comes with. So after giving the thrombolytic agents, we assess the patient after 60 to 90 minutes. If after 60 to 90 minutes of giving a fibrinolytic agent, if the pain has relieved, that means that the block has got cleared and there is flow which is persistently maintaining across the coronary artery. So relief of pain itself is an indication that the thrombolysis has gone successful. Second, sometimes the patient may present with hypotension. So, because all these patients are of acute MI or heart attack patients whose myocardium may be very much damaged. So, because of this, the patient may not have sufficient cardiac output to maintain blood pressure, and patient may be in hypotension. So because of this hypotension, if after thrombolysis, if hypotension gets improved, that means the block has completely cleared, and the myocardium has again started pumping well. So this hypotension has relieved. So resolution of hypotension is also another indicator where we can say that the patient has got successful thrombolysis. Third is attaining an electrical stability. So sometimes what happens is patient with myocardial infarction and all will have irregular beats like ventricular ectopics in between, or sometimes may have a non-sustained ventricular tachycardia rhythm which will be going on. So because of this infarction territory. So whenever there is infarction is clear, that is the blockage is clear, if a patient attains a normal sinus rhythm, ECG without any ectopics or something, that is also called as which is another indicator where we can say that the patient has gone a successful thrombolysis. So third thing is by ECG. Second thing is by ECG. How do we say ECG is that? So once you have seen that there is an ST elevation, so as I have shown that this is an ST elevation, if you have seen that, what you do is wherever the elevation is there, you can see the elevation is in one AVL, V1, V2, V3, V4, V5 also. So this is anterolateral wall MI. So wherever there is elevation, what you do is you can do two things. First, calculate the amount of elevations in all the ECG leads. Wherever there is elevation, you count the total of total amount of elevation which is there. So that you do by see, this is the baseline. From baseline, the amount of elevation which is there, you count. So each small square in this ECG is 1 millimeter. So you calculate number of small squares above the baseline where the ST segment elevation is there. So here it's approximately 9 millimeter. Here is approximately 2 to 3 millimeters above the baseline. So we calculate elevations in all these things. You calculate in the one, then in AVL, then in V2, V3, V1, V4, and V5. You calculate total amount of elevation in millimeters. And after doing a thrombolysis 60 to 90 minutes, you again take an ECG and again you calculate the amount of elevation. If the elevation has gone down by around 50%. So there is total of 50% resolution after 90 minutes. That means there is uh, successful thrombolysis. So another thing is sometimes this counting all these things can be very much difficult and cumbersome, and maybe a lot of need a lot of work. So sometimes what you can do easiest method is wherever there is maximum elevation. So suppose this V2 lead has maximum elevation among this in this ECG. Wherever there is maximum elevation in that ECG, after 90 minutes you take another ECG. If the elevation has decreased by more than 50%, that also means it is successful thrombolysis. And it has been seen that it correlates very well with angiographic reperfusion. And all this ST elevation should be calculated, right? It should be calculated, measured 80 milliseconds after the J point. Okay, so in any lead, it is after 80 milliseconds you have to measure. So suppose this is a J point here, this is a J point here. From here, 80 milliseconds means each small square is 40 milliseconds. So after two small squares, you calculate the elevation. So all the time, anywhere in any ECG elevation, if you want to calculate, you should calculate after 80 milliseconds of the J point. If that elevation is more than 80 milliseconds, that is two small squares. If it's more than two small squares, then it is called as MI. Okay, roller ECG with maximal escalation at the baseline, you compare that. You can see here, this is called as there is, you can see here elevation in the 2T, and you can see elevation in the AVF as well. And after successful thrombolysis, you can see the elevation has completely disappeared in this 2-3 AVF. So this is an inferior wall MI ECG. So as we have already discussed, that is sum of total elevation or a single lead with large ST elevation you will take into consideration. So you can see here again, so this was the baseline. If there is successful thrombolysis, the elevation has decreased. If there is not a successful thrombolysis, the elevation has persistent. Okay, then also you can have, there is a grading which has been given that for resolution of the ST elevation, complete resolution is said when if there is more than 70% of the decrease in the elevation. If partial resolution means 30 to 70%, and no resolution means less than 30% of the elevation. Other parameters in ECG which can also give you an indication that the thrombolysis has gone successful is by seeing presence of T wave inversions. So as you can see here, initially when there is STEMI, you cannot see an T inversion anywhere here. If after thrombolysis, if the patient develops T inversions, so if a patient develops T inversions like this, that means the elevation has gone and T inversions are there. That also indicates that is successful thrombolysis. Second is early inversion of terminal portion of T wave in association with ST resolution. So as I've already said, T wave, so ST will resolve and there will be associated T inversions. Third is recovery of R wave amplitude. Normally what we see is there is poor R wave progression we see in case of myocardial infarction as well in case of anterior wall MI. So I'll show you an example here. So you see here normally in a normal patient what happens is our patient, as you can see here, this is the R wave. This is the R wave. As you go on from V1 to V4, the R wave starts increasing and more. So see here S is dominating. This is S is dominating. Here R is dominating. So normally R gets dominated at level of V3 or V4. You can see here the R wave is keeps on increasing from V1 to V6. So whenever there is MI, this R wave progression is gone. You can see here the R wave, you can see here, see R wave amplitude is very much less when compared to the S wave. So R wave has not dominated the S wave. So this is suggestive of poor R wave progression, which is seen in MI. It also can be seen in other condition, but MI will have poor R wave progression. So suppose sometimes if the myocardium is completely damaged, this R wave will be completely disappeared also. So after thrombolysis, if that R wave amplitude increases, R wave becomes like this. The amplitude, if it increases, then it means that there is successful thrombolysis. Another thing is disappearance of Q waves. So here you can see here, this is a pathological Q waves. Any Q wave which is more than 2 millimeters is called pathological Q wave. This Q wave, if it disappears, is also an indication of successful thrombolysis. So last thing you can also see is reperfusion arrhythmias. Generally, if there is successful thrombolysis, there will be a rhythm called as accelerated idioventricular rhythm. And sign of reperfusion, it is seen up to 50% of patient may have this accelerated idioventricular rhythm. And sinus bradycardia associated with hypotension can also be seen in various patients. So this is a case of idioventricular rhythm where ventricle starts beating independently, irrespective of this. So there is no P wave here. You can see this is a normal PQRS, and this is accelerated idioventricular rhythm. So it may appear as VT, but generally in VT heart rate is around 150 to 200, whereas here the heart rate is generally around 60 to 120. Biochemical indices wise, so successful reperfusion can also be seen in case where there is a 4 to 6 fold increase in the lytic therapy. So what happens is normally this all these biomarkers which are there in the myocardium, it gets released into the circulation early because the block is cleared and there is lysis of these clots and all these biomarkers get released early in the blood, and there you may see after successful thrombolysis there will be 4 to 6 fold increase in the this enzymes of CKMB troponin T. So troponin T and CKMB will start increasing, coming into the periphery, but more earlier when compared to normal. And if there is 4 to 6 fold increase in the enzymes, along with the clinical findings of decrease in pain and decrease in ECG elevation, it also an indication of successful thrombolysis. So last thing is for the successful thrombolysis is finally by the most accurate one is the angiography wise. If you can see in anywhere in angiography, if there is flow is TME2 or TME3. So TME flow means TME0 means there is complete occlusion. That is there is no flow. You can see distally there is no flow. TME1 is small, faintly some filling will be there distal to the occlusion. TME2 means there is very slow flow. That is the flow will be there completely to the distal, but the flow will be slow. And TME3 is normal flow. So normally in during MI there is complete occlusion. Now what happens is in after sexual thrombolysis means if patient should at least develop TME2 or TME3 flow. So if they are developing this 2 or 3 flow, that means it is a successful thrombolysis. I hope you have understood this topic. So these 4 parameters: biochemical indices, ECG, and this clinical findings. Based on that, you can say whether the thrombolysis is successful or not. If you have any doubts, you can text me in the comment box. If you like my video, do share it with others and do subscribe to my channel. Thank you.